of our global palliative care program. And I'm actually a combined pediatric oncologist and palliative care physician. So I split my time between our solid tumor services, taking care of our patients on the inpatient side with any solid tumor or neuro-oncologic diagnosis, as well as help with our consulting service with our palliative care team, addressing any sort of the palliative care needs. And hopefully by the end of this talk today, you'll see how these two are integrated, how I'm able to do both, and how I see these two specialties as so well combined and so intertwined in all the things that I do. And that when I do high quality palliative care, I think that makes me a better oncologist. And when I'm a good oncologist, I think it also helps me in my palliative care work. And so it's, again, very excited to chat with you all this evening. So as far as our objectives today, one, it will be identify principles of high quality palliative care. Really, what is palliative care? Highlight specific palliative care needs for children with cancer, and understand how we can effectively integrate the two and how palliative care can be integrated into the treatment of children with cancer. And a special thank you to Dr. Justin Baker, who's been one of my mentors ever since I started this journey into this field, as well as was sharing some of the slides. And hopefully, I know that he was hoping to be there with you all yesterday and today. And we're going to try and figure out a way for us to all get out there to visit you. So really, the very first thing, before we can go into anything else, it's that understanding of what is palliative care. What does it mean? And I really like the definition that was established in 2018 from the World Health Organization that defines palliative care as the prevention and relief of suffering of patients and their families facing the problems associated with life-threatening illness, right? These problems include the physical, psychological, social, and spiritual suffering of patients, and the psychological, social, and spiritual suffering of family members. And I love this definition because I think it really encapsulates and captures what we do as palliative care professionals. And it's really addressing suffering, right? When we think of, when I think of my role as an oncologist, it's to treat cancer. When I think of my role as a palliative care physician, it's to treat suffering. And anything that we do, it's always keeping that in mind of what we can do.
Recording stopped.
I apologize for that. It kicked me out for a second, so that the meeting had ended. Let me share my screen again and we can go from here. Awesome. All right. So, like I was saying, as we think about palliative care, as we think about what we do, we need to think about how the efforts that we do and perform are addressing patient suffering and the different contexts within suffering, right? And that really it's important as well as we think about the fact that this is an ethical responsibility of all health systems, and that is an ethical duty of healthcare professionals to alleviate this suffering, right? And that, you know, this isn't that high access to high quality palliative care is a right, not a privilege, and that we need to ensure that all of our patients have access to palliative care, regardless of diagnosis, prognosis, or where they might live. And so how do we prevent and relieve suffering? And as you saw from that definition, right, that we defined suffering beyond just physical, right? I love Cicely Saunders' definition of total pain, right? This idea that pain is truly a physical as well as a psychosocial, spiritual pain. That when our patients are going through the suffering that they're going through for their treatment, not just the disease itself, but often the things that we do to try and cure them of their disease, the sacrifices that both they and their families have to make with regards to their social lives and leaving work, having to miss school, not being a child anymore, in many ways, because they are in the hospital constantly, receiving this treatment and dealing with the toxicities associated with their treatment, the existential crisis that occurs when they are trying to understand why this is happening to them. And then again, the anxiety, the fear, the depression that occurs. And so as we think about the suffering that our patients are going through, we have to think beyond just the physical suffering, but really thinking about those psychological, the social, and the spiritual aspects of the patients themselves, but also of the family members. And I think that's one of the beautiful things about palliative care, is that we're also thinking about the family and seeing this child beyond just an organ system or a cancer diagnosis, but really as a whole child with a community around them. And that our role is to help provide them the support structure necessary to help them navigate this incredibly difficult journey that is being diagnosed with a pediatric malignancy. And before we go any further, I want to try and nip this in the bud a little bit, as we say here in the United States, that, often people say, well, isn't palliative care the same as end of life care, right? Isn't that kind of what you guys do? And it's so much more than that. So this was a paper published about 15 years ago in Lancet that I think does a good job of kind of demonstrating the whole spectrum of what we provide as palliative care specialists. And that is, while yes, end of life care is a significant component of what we do in relieving suffering at the end of life, there's so much that happens before that, right? This individualized blending of care, addressing that suffering and the needs of the child and the family with consistent and continuous reevaluation and readjustment, as well as support after, right? In both survivorship as well as in bereavement care, where we're helping the families navigate that loss. And while I like this figure, it came about 15 years ago, I do like this a little bit more. And you can see this is from a paper published in 2011, where it kind of goes through a little bit more seamlessly that integration that exists, the high quality integration that could occur. Where with this first one, it's very blocky, right? Okay, we're going to treat to cure. Okay, we can't cure anymore. Now it's all palliation, and then it's death, and then it's bereavement. And it's very choppy, right? And there's the really sharp contrast between what's happening and versus more of a parallel approach, where palliative care is in the background at the beginning. And as we see a patient is relapsed, or a patient is no longer has any cancer curative options, palliation takes more of a role. And while this looks good, and I like this a little bit better, I really love this integrative approach. And again, we're going to use that word integration quite a bit today as we talk about how we can really provide high quality care for our patients. It's that seamless merging of curative intent as well as healing. And that's actually what introduced me to palliative care in the first place. When I was a medical student, I had an oncologist who was taking care of, and I was on the medical team with them. And we had a patient who had infant leukemia, infant ALL, that had relapsed. And the child was the same age as my son was at the time. And I was really struggling personally in thinking about what I would do or how I would act if I were the father in that situation. And if my own son were to be dying of cancer, and putting myself in the father's shoes, and just how devastating that would be for me. And I was really struggling with that concept. But one of the physicians there was a dual trained oncologist and palliative care specialist. And he introduced this idea of curing and healing. And so in English, we use two words to describe these things. One, to cure, right? Which is really addressing the physical elements, that we cure someone of their disease. But then there's the second element of healing, right? And that the healing, there's a lot more depth to that, that not only is it something in which we can cure them of their physical malady, but also address that total pain that we're talking about, the spiritual healing, the social healing, the psychological healing. And that there may be some patients that we will be unable to cure of their disease, but we can still provide healing. And there may be some patients that we will heal that we can't cure, and vice versa. And intersected in all of that is that understanding of hope, right? That hope is an integral component of what we do in palliative care, and that we don't take away patients or families' hope when we are faced with these incredibly difficult circumstances. We help them integrate their hope into other things while also supporting them in that bereavement process, knowing that bereavement there's anticipatory grief that may occur, and helping them navigate that anticipation of their loss. And so I really like that bottom model, and where we're seamlessly integrated within that process, that not only we're providing things with curative intent, but also thinking about how we can provide healing, and at the same time integrate hope and understand of that loss that might be happening, regardless of the outcome and their diagnosis. So again, what is palliative care, right? So it's active total care of the child and the family, really focused on quality of life. How can we make this child's day just a little bit better? Knowing that they're going to have to go through chemo, knowing that they're going to have to go through surgery, knowing that they're going to have a long road. How can we help them still be a child in the best way that we can? Reduce that physical, social, psychological, and spiritual suffering. And it occurs from diagnosis, right? And then it goes well beyond treatment. And by nature, because we're focused on all of these facets of the child and the family, it's really best achieved as an interdisciplinary team. When we work together as physicians, nurses, social workers, psychologists, child life specialists, spiritual care advisors, right? The whole team, and included in that team is the patient and the family, to really think about how we can ensure that the goals of care are aligned between the medical team, the patient, and family, and to achieve those goals of care. The other thing that I really love about palliative care is that we're not confined to the walls of a hospital, right? That there are opportunities in palliative care to provide treatment in the hospital setting, in an inpatient unit, in an outpatient clinic, in a physical location of a hospice or end-of-life facility, and even in the home in the community, right? That we can provide home-based care to try and get these patients into a setting that is more aligned with their goals at the end of life. And so really, no matter where the patient is, we can provide those touch points to be able to best support them and their needs. And one of the things that you'll often hear, and I want to make brief mention of this, is this differentiation between primary palliative care and specialty palliative care, where primary palliative care are these basic management of pain and symptoms, right? Anytime you provide ondansetron to address nausea for a patient who's having a metagenic chemotherapy, that is palliative care. You are addressing that patient's suffering. Anytime you are sitting with a mother and after sharing difficult news and holding her hand and comforting them, you are providing palliative care, right? You don't have to be a specialist who's trained for many years to do that, right? You can still be a high quality palliative care provider by providing these basic things, right? Specialty palliative care is where you do have that additional training, where we recognize that some of these pain and symptoms that our patients are experiencing are refractory to our common treatment modalities. And we receive this additional training to use adjunctive agents, to be creative in all of the different ways to address their pain and symptoms. But also, in addition to the physical symptoms, as I've alluded to, complex depression, existential distress, etc., helping with conflict resolution and assistance in addressing cases that are particularly difficult. And so I think that this is really helpful as we have this context of the fact that, a patient is suffering, and that throughout all of their care, we need to be thinking about this, that even when I'm wearing my oncologist hat and I'm treating my patient with neuroblastoma, I'm constantly thinking about what are some of the things that they're suffering from that I can address, as I'm also thinking about how to cure them of their disease, right? And then if they're having refractory symptoms, I can think a little bit more from that specialty palliative care perspective to how to better integrate these novel modalities to address that. And this is something that we can see in the trajectory and health functions over time, right? This is a common scenario that we often face where a patient is doing okay and then something happens and then they bounce back, but they don't quite bounce back to where they were from the beginning, right? Or then they relapse and then they do a little bit better, but then they get sick again, they get sepsis, and then we're able to give them antibiotics and they feel a little bit better and they recover for a little bit, but eventually they succumb to their disease, right? And so often we think about these opportunities for providing palliative care and specialty palliative care and where those thresholds are, right? And this isn't a fast and hard rule that at this moment in time, we provide specialty palliative care versus primary palliative care. And because this line can move based off of the needs of the family and the needs of the medical team. But just kind of getting that idea of when are those opportunities for engagement with the palliative care team themselves, that's those subspecialists that are there. And so really, when I think about this question, who can provide palliative care to patients and families, I think the answer is everyone, right? All of you in the room today are palliative care providers. And hopefully some of you are interested enough to be palliative care specialists, where you can think about how to take that additional step to really understand how to address those refractory elements of suffering and understand when to call your colleagues to be integrated into that. Now, why is early integration for children with cancer so important? We've now talked a little bit about patient suffering and what palliative care does in addressing that suffering. Now, why does it matter in pediatric oncology specifically? And I think the short answer is because our patients are suffering significantly, right? Probably one of the most important papers that really set the standard for us in the field of pediatric palliative care came out from Dr. Joanne Wolfe from Boston Children's in 2000, where she showed that patients are suffering. These are children with cancer at the end of life, and that almost all of them are having significant symptoms from fatigue, pain, dyspnea, poor appetite, nausea and vomiting, constipation, etc., near the end of life, and that they are not being treated appropriately, right? That some of these are being treated, but that the treatment being successful is quite low, right? So a pretty sobering manuscript demonstrating just how far we needed to go to help address patient suffering. And as we see in follow-up work in 2015 by Dr. Wolfe, is again, there's still a high prevalence of symptoms that are causing a lot of distress for our patients and families. Look at the list of all of these different symptoms, both from a physical standpoint, as well as from a psychological standpoint and an existential standpoint. And the fact that we have to be better about addressing this. And so why is early integration for children with cancer so important? It's because our patients are suffering, right? And that there's a lot of different elements that we think about when we think about the suffering of our patients. One is it's disease related, right? That if a patient has a high grade osteosarcoma in their leg, that is painful. It's uncomfortable, right? When they have metastatic disease to their lungs and they're having difficulty breathing, right? That the disease itself is causing suffering. Often, as you all know too, when we treat our patients, right, with highly toxic chemotherapy, with radiation therapy, with these aggressive surgical resections, right, we're also causing suffering with the hope that we'll be able to overcome their disease and cure them, and recognizing that we are causing suffering, right? Whenever we give cisplatin or other highly emetogenic chemotherapies, right, we are causing nausea and vomiting, we're causing suffering, and we need to make sure that we're thinking about how we address that. Again, as we've alluded to, there's an existential distress, the psychological distress of what it means to have cancer, how that impacts them in their society, how that impacts their relationship with whatever spiritual or religious organization or affiliation that they may have. And even system-related suffering, right? I think all of us can see those challenges that we have within our own healthcare infrastructure that impedes us from providing high quality care for our patients. And so not only are we dealing with the disease itself and the treatment itself, but also those system issues that can exacerbate suffering. And so there's a whole host, and it's not a perfect pie chart like this, but I think these are definitely some of the things that I think about with our patients in particular and how they suffer. And so again, why is it early integration for children so important? It's because our patients are suffering, and early integration of palliative care can reduce and alleviate that suffering. And so really that's the question, right? Can it? And the answer is yes. And so there's a great review article that was published a few years ago from one of our colleagues here at St. Jude, Erica Kay, that shows that really asks this question: does palliative care make a difference for children with cancer? Does that early integration really make a difference? And the answer is yes, right? More patients were likely to be enrolled in hospice and die in their preferred location, in particular, often the home, if they're enrolled in palliative care or had palliative care involved earlier in their care. They had improved symptom burden and management, right? We saw those figures from Dr. Wolf from 2000 and 2015, and in subsequent efforts, we were able to see that the symptom burden and management was better when palliative care was involved earlier. We're not perfect and we still have a ways to go, but we are able to address their pain better. When palliative care is involved, those specialists in palliative care who've received additional training in how to manage symptoms, when they are involved earlier and when palliative care is a focus from the beginning, our patients' symptoms improve. I hope that's one key takeaway that you get from this. Improvement in the perceived quality of life, including meaningful events at the end of life, right? So that natural progression of when they're feeling better, both from a symptom management standpoint, but also when we're thinking about the holistic element of care and the quality of life and the psychological elements and the social elements and the spiritual elements, these patients and families have a perceived quality of life that is better than those that did not have palliative care integrated earlier, and that they have these meaningful events that provide them purpose and strength despite the challenging circumstances that they're facing. Another logistical element and tangible element is that when palliative care is involved earlier, it decreases hospital admissions, it decreases ICU stays, it decreases intubations and ED visits, right? That they have less interaction and touch points with the hospital and are able to spend more time with loved ones, right? That they're and aren't quite the same burden on the healthcare system. Not to say that we wouldn't want to care for them or interact with them, but that they don't utilize all of these resources. Additionally, this idea of communication, right? That when we have palliative care specialists involved from the beginning, that improved communication between the healthcare team and the family. And along those lines, that we have those conversations with regards to advanced care planning, understanding what the goals of care are for the patient and family at the end of life, and making sure that we are honoring their wishes. Additionally, this idea that when we do these things, when we provide high quality care, one, we're already seeing that it's better care for the patients, and these patients and families see that they're more satisfied with their care when palliative care is involved earlier. And even a potential reduction in cost, again, as they're not utilizing all of these resources at the end of life, that those resources are able to be allocated for other patients, especially in thinking about those situations in which resources are tight, in which there are constraints to the healthcare system. The ways in which, by providing this higher quality of care, what the patients want, as we can see from this, and deserve, which is better for them, it also seems to be more cost efficient and better overall. One of the key takeaways from this, and I hope that you guys take this away as well, is that earlier palliative care referral did not result in earlier mortality, right? And so we have all of these benefits of improved pain and symptom management, improved quality of life, improved communication, decreased hospitalizations, more likely to spend time with loved ones and have these meaningful events. It did not result in earlier mortality. So just because palliative care gets involved earlier does not mean that this patient is destined to die. And in fact, we get consulted all the time here on patients that actually have a fairly good prognosis. and yet they are suffering in different ways, and how we can best support them. And so I, again, want to reiterate that palliative care is not synonymous with end-of-life care, and that by getting palliative care involved, it does not hasten a child's death. So who then should be referred to palliative care? All of our patients and their families should have an integrated approach from the point of diagnosis. That does not necessarily mean that all patients have a formal consult from the full palliative care team, but that from the very beginning, we're thinking about what are the elements of this child's care that may result in suffering and how we can address that. And again, thinking about that primary and specialty palliative care approach. Now, again, this is great and all, but I just don't think our patients are ready to meet the palliative care team. We don't want them to lose hope, right? This is something that we often hear. And I think that this study that also came out of our team here at St. Jude from Dr. Levine really addresses this, nips this in the bud, that when patients and parents are asked about palliative care and are taught what palliative care is, they actually want it, right? And so over half of them felt very positively about involvement, and only about 10% were not, and the others were unsure. And this is of the child, and even and about the same for the parent, right? So over half of these parents and patients want palliative care involvement, especially after they learn what it is. And so really at the end of the day, it's not necessarily the patients and families that are concerned and don't necessarily want it, but it's us as healthcare professionals that aren't ready for palliative care to be involved. And so it's something that we need to work on as a pediatric oncology community, is to think about it ourselves and realize that actually palliative care can be an incredible asset for us throughout treatment, and that the patients and families are not the ones that are not ready. It's us, and that we are transferring our own views on this onto the patients and families. And so as we think about this then, right? So we've now been able to identify that palliative care addresses patient suffering, that it's not just end-of-life care, that it provides incredible benefits to the patient and to the family, and that these families actually want it. How can we integrate this approach? And so I love this picture of Woody from Toy Story, anxiously awaiting a phone call from his oncology colleagues so that he can be involved as a palliative care specialist. And so when I think about integrated approaches to pediatric oncology, it's so much more than just having a palliative care professional or team in the hospital, right? It's more than just having a palliative care specialist in their office just waiting for someone to call them. It's really an active approach. And this is a model that we published about 7 years back that shows this integration. And there's three main tiers that we think about when it comes to this integrated model, from the institutional level, from a specific population level, and from an on-demand level. And as you can see, we really think about the resources and how many resources are involved, but then also the patients and families served. So we'll go through each one of these. So at this first level, at the institutional level, right? This is really where we provide training for all staff in the basic principles of palliative care, right? That we help ensure that everyone, whether they're nurses, whether they're respiratory therapists, whether they're physicians, whoever they may be, they're all basic primary palliative care experts, right? And some of the things that we do here, again, is we require communication training for our clinical fellows, right? So from the very first day that you're on campus, in the very first week during our orientation, we meet with bereaved parents to walk through and learn how to communicate effectively, right? We provide institutional support for outpatient hospice resources. We create evidence-based hospital-wide pain management standard operating procedures. We do all of these things so that every patient who comes to St. Jude gets the care that they need and deserve to address their suffering, and that every member of the staff in the hospital understands basic principles of palliative care, understanding those basic principles of pain and symptom management, these high quality principles of communication, et cetera, so that we can reach as many patients as possible. And again, it's fairly simple resources, right? We're not doing a ton of resources into this. We're providing generic education to everyone, any new employee, gets the opportunity to learn some of these basic principles to understand how to apply to their patients and families. The next level is a specific population. So thinking about those patients that are high, what we call high risk, right? These patients with diffuse intrinsic pontine gliomas or metastatic osteosarcomas, these patients that have a pretty poor prognosis regardless of our treatment modalities. I mean, patients on phase 1 clinical trials who, we know the prognosis is poor. In these populations, we actually have an automatic trigger for consultation. So if there's a new patient that comes in with a diagnosis of a pontine glioma or a high-grade glioma, they'll automatically receive a palliative care consult. And that may be the only consult they get in the beginning of care. And they say, okay, we're good. We don't necessarily need to meet with you right now, but they've had the chance to meet with us initially. Our bone marrow transplant patients, every patient who gets a bone marrow transplant at St. Jude has an initial consultation as a part of their transplant workup. They may never see us again, right? But we know that that's a high-risk population that has a high risk of suffering, and therefore we want to make sure that we are thinking about that in their care. In addition to these specific populations, another population are those that are at the end of life. And we've actually created a patient checklist and dedicated rooms in the hospital so that patients and families can be there. And we have embedded palliative care professionals in different teams. And I believe this is something that you guys are working on out there, where as opposed to having a consult service that's sitting in their office waiting for a call, there's actually these palliative care experts who are within the teams who, when they see a need, can say, hey, actually, this is a patient that may benefit from a palliative care consult. We actually have in each service, in each tumor board conference, we have a palliative care specialist who's listening in on those calls who may say, hey, I hear that there's a new patient coming in with widely metastatic Ewing sarcoma. I know that that's a tough diagnosis, and it sounds like there's a difficult social situation, that mom's by herself and has multiple kids. What are your thoughts about having palliative care be involved, just to see if we can provide an extra layer of support, right? And so we have those specific triggers for specific patient populations, end of life care specifically, and a checklist for that. But then also having our palliative care professionals embedded within the different teams to be those supports for the primary teams. And then finally, this on-demand consult base, where a primary oncology team requests an expert palliative care consultation to assist with complicated symptom management or difficult social issues, right? This is the patient that's had run-of-the-mill care, but is really having significant post-operative neuropathic pain, and we need to get creative as far as managing that because they've got phantom limb syndrome or things along those lines. And so this is kind of the traditional model. But I think it's so important that we think about how all of these things integrate, how all of these things are come together to provide high quality palliative care across the spectrum. And so that there are touch points for all of our patients who enter St. Jude's walls. And again, that some of these are easier to integrate than others, and that, having a specific palliative care team is great. And how can we integrate it a little bit better? And it's important to know that this didn't happen overnight, right? That this isn't something that we woke up one morning here at St. Jude and that automatically we had this incredible system, right? That this took 15 plus years of dedicated work to build this, right? And so as we look at this journey, I have to have pictures up of Dr. Justin Baker, right? Because he was such a pillar in the growth of this program, with the support of many other people, Pam Hines, a nurse researcher, Javier Kane, another physician. And so you had to have some key champions within the institution to grow it. And so in 2006, they hired their first medical director and really started this pilot, and that it continued to grow. And in 2008 is when it really started as the first institution-wide service. So that was really 15 years ago. And then starting to build a home-based hospice system and care, starting to do the research to demonstrate the efficacy of our work, building a palliative care fellowship program and getting new trainees, the next generation of experts in this, having a day of remembrance and really engaging with our bereaved parents and their priorities, right? Having the opportunity to do a combined fellowship, what I ended up doing in both palliative care and pediatric oncology. And then seeing the work product of this, seeing the expansion of this care, seeing the fact that we then had a pediatric palliative oncology symposium, having hundreds of people from throughout the United States come to learn from St. Jude, right? And then continuing to grow and seeing over 750 consults, right? And then into a global space. And that's really where I came in here in 2018 and seeing the growth of this with the global palliative care program. And obviously when COVID hit, to then integrate telehealth into our efforts, to do these things virtually, to still have both the educational as well as the patient care work done on a virtual element, and then integrating integrative medicine and having a consult service for that to provide acupuncture, aromatherapy, et cetera. And then fully embedded our team within those, again, as that embedded integration of having palliative care trained experts integrated into each team to provide that extra level of support and growing all of these efforts. So again, as you've seen, this has been a 15-year process that we've gone through and slowly but surely develop what it is. And we still have work to do. There's still patients that we aren't interacting with as well as we could, and as deeply as we could. And so we're constantly trying to find ways to improve and continue to ensure that every patient receives that high quality palliative care. And that's where we are globally, right? So how do you get there, right? So one, as we've talked about, you recognize that access to high quality palliative care is an ethical responsibility, right? This is a right, not a privilege, and that all of our patients deserve this. We help colleagues recognize they are the ones that are not ready, right? And that really these patients and families are ready for their suffering to be addressed, and they want it, right? We build a sustainable and scalable process for integration, right? That it's not something that you do overnight, but slowly but surely build these different models into place between your educational initiatives, between your interactions with your colleagues, and then having that formalized team. And I would add two more, right? The other big things that we've done is we've included key stakeholders, and in particular, parents and families. One of the biggest things that helped us grow is when we interviewed several bereaved parents and families, and they set a list of priorities of the things that they felt we needed as an institution to improve our palliative care. And learn from what you do, publish your efforts, refine and repeat, right? That one of the things that we've been able to do is continue to learn and grow and not be complacent with our successes, but learn from our challenges, learn from our mistakes, and continue to get better. As I mentioned, our bereaved parents have been essential for this growth, and that working with them has been one of the biggest successes of the palliative care program. And these are the priorities that they set to really that they get the best possible treatment of the disease and have the best possible quality of life, that those aren't mutually exclusive, right? That we provide effective symptom-based control, that we provide relationship-based care, that we empower families with useful and reliable information, and that we support them, and that they receive the care that they need wherever they need, and that they receive the bereavement support for surviving family members and hospital staff. So this information was actually taken to the CEO of the hospital and said, this is what parents want. And once that happened, many of these successes occurred. And so I encourage you all to consider how to engage parents in this. And by having their voices heard, it will help ensure that our patients get the care that they deserve. And these are some of the things that we now offer. We have bereavement care planning. We have staff education that we have a day of remembrance. We actually have bereaved parent mentors that work with each other to help each other. And we're doing a lot of research in this space. And so again, another great opportunity as you think about the growth and development of a palliative care experience. So this is, again, our service now, right? A large growing service of physicians, nurses, a research team, our global faculty, a psychologist, administrative support, right? And again, I hope that you look at this as something that's aspirational and recognizing that this didn't happen all in one day, but slowly as we've continued to learn and grow and develop and see where those needs are and engage with patients and families to see how we can best serve them. This is also our outpatient team, right? And the fact that we now provide services in the home and in our housing to be able to provide them that care both in and out of the hospital, as I mentioned. And so as we've seen this change, as I mentioned, in October is when the palliative care service first developed, institution-wide. And then as we've had these different quality improvement initiatives and the build of quality improvement, the bereaved parent priorities, right? Eventually, we've now gotten to this point where all of the patients who die at St. Jude have a palliative care consult. And so in conclusion, Dr. Baker talks about the different stages of palliative care development, right? And so the first stage is denial, right? Where there's no institutional awareness of need. The second is palliaphobia, where there's an institutional recognition of the need for palliative care, but the question of the importance and fear moving forward. Stage 3 is pallialia, which is an institutional recognition of the need and importance, but just under-resourced. You don't have the resources that you need to be able to grow. Palliactive. This is where you're really starting to recognize the need and the importance, and you're starting to be embraced by the institution as a whole. You've got the staff, you've got the resources, but then that last stage, and what we really hope to get to, is that pallia paradigm shift, where you redefine the field of quality of life in palliative care. You create the standard of care for early integration into the ongoing care of children with catastrophic illnesses. And this is where we all want to be. And this is where I see you all and all the great work that you're doing, not just in Ho Chi Minh, not just in your hospital, but for your country and for the region as a whole, by setting that standard, by redefining what this looks like for your patients and their families, and being able to move the needle forward to provide the best quality care that you can for children with cancer, regardless of their diagnosis, their prognosis, or where they live. Thank you so much for taking the time to listen to me talk today, and I'm available for questions.
Thank you very much, Dr. Michael, for the amazing talk. And thank you very much, everybody, for joining us with. Do you all have any question? Anyone has any question? Em có câu hỏi. So, Dr. Michael, please stay with us for a while so that we can take a group picture.
Of course, I would love to.
Yeah. Anyone has any question? All right, so if there's no question, we can take a group picture. And thank you everyone for joining with us today.
Perfect.
Let's take a picture. Wait, yeah. Lên, các em lên đi. Phóng hình thầy ra đi. Phóng hình thầy.